So it's 3 o'clock in the morning.
Oh, the classic ER witching hour.
Right. The emergency department waiting room is packed. You've got those fluorescent lights buzzing with that awful sterile hum, and a patient walks in clutching a plastic basin. They are heaving.
Yeah, we've all been there.
It's honestly quite possibly the most common, seemingly mundane complaint in human history. They're throwing up.
Absolutely.
And if you're the doctor standing there, especially if you're exhausted, your first instinct might just be to, hand them an IV, push an anti-nausea pill, and just assume they ate a questionable piece of fish.
Which, to be fair, is statistically likely.
Yeah.
But it's also practically terrifying.
Right, because of what else it could be.
Exactly. Because that exact same presentation of patient bent over a basin could be a self-limiting viral bug, or it could be a rapidly ticking, life-threatening time bomb.
Wow.
Yeah. Distinguishing between those two extremes, especially when the surface-level symptoms look totally identical, well, that's one of the ultimate tests of a diagnostician.
So that is our mission for you today. We are doing a deep dive, a really comprehensive physiological masterclass on how to crack the code of vomiting in the ER.
A full algorithm.
Exactly. We are building a detailed, high-efficiency mental algorithm designed to take you from the very first moment of history-taking all the way to the precise, molecular-level dosages of life-saving medications.
But before we even start building that algorithm, we have to look closely at the patient in front of us and separate the signal from the noise.
Meaning what, exactly?
Meaning, according to the strictest clinical guidelines, not everything that comes out of a patient's mouth actually qualifies as vomiting.
Wait, really?
Yeah, we have to differentiate true vomiting from two major imposters, which are regurgitation and rumination. They represent entirely different mechanical failures.
I would imagine the difference there mostly comes down to effort, right? Like, if the digestive system is basically a complex plumbing network, regurgitation feels like a slow drain just passively backing up.
That is an incredibly accurate way to look at it. Regurgitation is completely effortless.
Just passive.
Right. Passive backing up of food or liquid. The patient might simply lean over to tie their shoe, and fluid just spills into their mouth.
No heaving at all.
No heaving.
Yeah.
Anatomically, this tells you the problem isn't in the stomach, it's in the esophagus.
Ah, okay.
It's just a structural roadblock, like a stricture, or a condition called achalasia, where the lower esophageal sphincter, that's the valve right above the stomach, it simply refuses to relax.
So the food just stacks up in the pipe.
Exactly.
And rumination, where does that fit in?
So rumination is also involuntary, effortless, and painless. But it typically happens within minutes of a meal. The food backs up into the mouth, and the patient often, they re-chew and re-swallow it.
Oh, wow. That sounds awful.
It's an entirely different behavioral and physiological loop.
Which means true vomiting is something else entirely. It's not a passive backup. It's the emergency pressure relief valve violently blowing off steam.
Yes. It is a violent, highly coordinated full-body physiological event. It's the forceful retrograde ejection of stomach contents.
Retrograde, meaning going the wrong way up the tube.
Right. And the defining feature is the severe involuntary contraction of your abdominal muscles and your diaphragm.
It looks exhausting.
It is exhausting. The patient is sweating, their heart is racing, they are physically heaving. So your very first observation as a physician is just looking at the abdominal wall. Is this an active muscular expulsion?
And if the answer is yes, the alarms are officially sounding. And our job is to figure out exactly why the body pulled that alarm in the first place.
Exactly.
So where do we even start?
You start by mentally sorting the patient. You don't touch them yet. You don't run a scan.
Just observing.
Right. You create a mental map based on the immediate threat level. We divide the landscape into 3 distinct diagnostic categories, starting with the absolute worst-case scenarios.
The abdominal disasters.
Yeah.
The gastrointestinal emergencies where the clock is practically visibly ticking.
Exactly. If you miss a diagnosis here, the patient could deteriorate and die within hours. We are looking for the big 3, which are intestinal obstruction, acute pancreatitis, and appendicitis.
Let's put some physiological reality to those. If I have an intestinal obstruction, my internal plumbing is literally blocked.
Completely blocked.
So maybe scar tissue has clamped down on the bowel, fluid, gas, and digestive juices are just ramming into a brick wall, stretching the intestine like a balloon.
Yes, stretching it until the tissue gets so thin it cuts off its own blood supply.
Which leads to bowel ischemia. The tissue just starts to suffocate and die.
Right. Or take acute pancreatitis. The pancreas is basically a factory that produces highly potent digestive enzymes.
Like chemical scissors.
Exactly. Normally, these enzymes are inactive until they safely reach the gut. But in pancreatitis, they activate early while they're still inside the organ.
Oh, that sounds disastrous.
It is. The pancreas literally begins to digest itself. It spills highly toxic inflammatory chemicals directly into the abdominal cavity.
And then there's appendicitis, the classic ticking bomb.
Right, the one everyone knows.
A tiny pouch off the large intestine gets blocked by a hard piece of stool. Bacteria multiply wildly inside it. It swells with pus, and if it bursts well, it fires infectious fecal matter directly into the sterile space of your abdomen.
Literal biological bomb.
So those are the immediate surgical terrors. But if the patient doesn't seem to be in, like, immediate agonizing, shock-inducing pain, where does our mind go next?
We move to the second category, which is the gastrointestinal non-emergencies.
Non-emergencies, but still awful.
Oh, highly painful and distressing for you as the patient, but they aren't about to kill you in the next hour. This includes things like gastritis, which is simply a raw, inflamed stomach lining, or gastroenteritis, your classic infectious stomach bug.
What about organs that are outside the main digestive tube? Do they fit here?
They absolutely fall in here. Hepatitis, which is profound inflammation of the liver cells, often from a virus. Cholecystitis, a severe gallbladder infection.
Usually triggered by a gallstone, right?
Right. When a gallstone acts like a cork, blocking the exit duct and letting bacteria fester behind it. And renal colic, which is the excruciating, undulating pain of a kidney stone tearing its way down the ureter.
It makes sense that a kidney stone would cause vomiting. I mean, the pain is so legendary, your nervous system just sort of short-circuits.
It completely overwhelms the system.
But that brings us to the third category. And this is where I think the real medical detective work begins, because the sources talk about a category of conditions that have absolutely zero to do with the stomach or intestines, but they trigger violent vomiting anyway.
Right, the non-GIT systemic causes. These are the masqueraders. And to ensure you don't miss a silent killer while you're busy examining someone's stomach, ER doctors use a rapid recall mnemonic spanning from A to H.
It really is a terrifying tour of how interconnected the human body is.
It is. Let's start with A. A stands for Addison's disease, acute kidney injury, and chronic kidney disease.
Wait, if my kidneys are failing, why is my stomach emptying itself? I get that they are neighbors down there in the abdomen, but they don't share plumbing?
They don't share plumbing, but they share a blood supply. Your kidneys are the master filtration system.
Right.
When they fail, they stop filtering out nitrogen-based waste products, leading to a condition called uremia. This highly toxic blood circulates out of the kidneys and travels all the way up to your brain.
Oh, so it hits the brain.
Yes. Deep in the brainstem, there is a specialized, highly porous cluster of cells called the chemoreceptor trigger zone. It's designed to act as a chemical sampling station.
Like a taste tester for the blood.
Exactly. It tastes the uremia, recognizes it as a deadly poison, and pulls the fire alarm to purge the stomach, assuming you must have eaten something toxic.
It's vomiting to save you from a poison that your own body manufactured. That's a brilliant, if deeply flawed reflex.
It really is.
And Addison's disease, where does that fit in the A's?
Addison's is an adrenal crisis. Your adrenal glands sit on top of your kidneys and produce cortisol, which is your primary stress hormone. Cortisol is what keeps your blood vessels tight and your blood pressure stable.
So without it?
Without it, if your adrenals fail, your blood pressure completely collapses. And that massive sudden shock to the system presents with profound nausea and violent vomiting.
Okay, what is B?
B is for brain, specifically increased intracranial pressure.
I'm assuming this comes down to the simple physics of the skull. It's a rigid bone box. It doesn't stretch.
The Monroe-Kelly doctrine, exactly. Your skull cannot expand. So if you develop a brain tumor or an aneurysm bursts and bleeds inside your head, or meningitis swells the brain tissue itself, that extra volume has nowhere to go.
It just builds up.
Right. It massively increases the physical pressure inside the skull.
And what does that pressure actually do to cause vomiting?
It forces the brain tissue downwards, physically squeezing the brainstem. And the brainstem is exactly where the vomiting center lives. The pressure literally mechanically crushes the nausea circuitry into firing.
That is deeply unsettling. So the body is throwing up because the brain is literally being suffocated.
Yeah. pretty much.
Okay, C is cardiac, specifically a heart attack, a myocardial infarction. How does a dying heart muscle mimic a stomach bug?
It all comes down to a massive bundle of wiring called the vagus nerve. The vagus nerve is the primary information superhighway for your internal organs.
Like a fiber optic cable.
Yes. It wanders from your brainstem down through your chest, plugging into your heart, and then continues straight down to plug into your stomach and intestines.
So it's a shared network line.
Precisely.
Yeah.
If the inferior wall of your heart muscle starts dying from a lack of oxygen, it screams in agony. It sends massive panic signals up the vagus nerve.
Okay.
But because the stomach also uses that exact same nerve to report pain, the brain gets overwhelmed by the cross-traffic. It misinterprets the cardiac distress signals as profound stomach agony.
So the patient feels nauseous and vomits, completely unaware that their heart is actually the organ crying for help.
Exactly. It's a literal crossed wire on the server rack.
That is wild. Okay, moving to D.
D is for diabetes, but specifically diabetic ketoacidosis, or DKA.
I know this is a critical emergency, usually for type 1 diabetics.
Yeah.
What's the cellular mechanism that leads to the vomiting there?
When a diabetic entirely lacks insulin, their cells are starving, even though their blood is packed with sugar. Insulin is the key that unlocks the cell door.
Right, without the key, the sugar is useless.
Exactly. Without it, the body panics and starts burning stored fat for fuel at an uncontrollable, catastrophic rate. And the byproducts of burning all that fat are highly acidic molecules called ketones.
So their blood literally turns acidic.
Yes, their blood pH drops dangerously. This severe metabolic acidosis highly irritates that same chemoreceptor trigger zone in the brain. They start vomiting violently, which is tragic because vomiting dehydrates them further.
Which concentrates the acid even more.
Right, accelerating the DKA crisis.
A completely vicious cycle. What about E?
E is for ear, the vestibular system. We are talking about severe vertigo, labyrinthitis, or Meniere's disease.
Right, the inner ear manages balance. It's full of fluid and little hair cells. But how does an ear problem translate to my stomach?
It is an evolutionary defense mechanism. Your inner ear is constantly telling your brain where gravity is and how your head is moving. Your eyes are also sending data about your position.
Okay, so the brain is constantly cross-referencing.
Exactly. If your inner ear becomes inflamed, say, from a virus, it starts sending chaotic, frantic signals, telling the brain you are spinning wildly.
But my eyes are telling my brain that I'm just sitting perfectly still on a couch.
Yes. And the brain's deep evolutionary logic kicks in. It says, my inner ear and my eyes are wildly disagreeing. The only logical explanation in nature for this kind of severe neurological mismatch is that I've ingested a neurotoxin.
I must be hallucinating from eating a bad berry.
Exactly.
Yeah.
Therefore, I must instantly purge whatever's in my stomach to survive.
Wow. It's an incredibly smart system acting on really bad intelligence.
It really is.
Moving on, F stands for foreign substances, toxins, and drugs.
This is a massive umbrella. It includes obvious things like severe alcohol intoxication or chemotherapy drugs, which directly assault the gastric lining and the brain.
Right, the classic culprits.
But it also includes common medications that reach toxic levels. A prime example is digoxin, a drug used for heart failure.
How does digoxin cause vomiting?
Digoxin works by partially disabling the sodium-potassium pumps in the heart cells to make the heart contract harder. But if the dose gets just a little too high, it starts disabling those pumps in other tissues too.
Including the nausea centers.
Yes, heavily stimulating the vagus nerve and the brain's vomiting centers. Or take massive doses of aspirin, which directly irritates the stomach and simultaneously acidifies the blood, hitting the nausea trigger from two different directions.
A double whammy. Then we have G for gravidity or pregnancy.
Specifically, the profound physiological shifts in the first trimester. As a fertilized egg implants and grows, it produces massive amounts of a hormone called human chorionic gonadotropin, or HCG.
Which triggers the morning sickness?
Right. These hormonal surges heavily stimulate the emetic centers. Biologists believe this, too, might be evolutionary, making the mother hypersensitive to slightly spoiled food during the most vulnerable weeks of fetal development.
That makes total sense. And finally, H.
H stands for hyponatremia and hypercalcemia. These are severe electrolyte imbalances, dangerously low sodium or excessively high calcium in the blood.
Electrolytes are essentially the charged particles that allow nerves to fire.
Exactly. They dictate the electrical voltage across every single cell membrane in your body. If your sodium drops too low, water rushes into your brain cells, causing them to swell.
Cerebral edema.
Right. And if your calcium spikes too high, it blocks normal cellular communication, Both of these massive electrical and physical disruptions cause the brain's nausea circuitry to misfire chaotically.
Okay, let's zoom out and look at the sheer scale of this problem. You're the ER doctor. You have a patient heaving into a basin. Their actual underlying crisis could be a twisted intestine, a suffocating brain, a dying heart, a viral ear infection, or toxic blood. In the chaos of an emergency room, you cannot run 50 different expensive scans to check every single organ. Time is tissue.
Absolutely.
So how do you safely cross things off this massive A to H list?
You have to act as a real-time medical detective. This brings us to step 2 of the algorithm, which is the high-yield history. You need to ask the fewest possible questions to extract the maximum amount of diagnostic data.
You essentially interrogate the symptom?
Yes, you interrogate the vomit.
Let's run the interrogation. What is question 1?
Question 1 is simply, what is the exact timing in the day? When does the vomiting happen?
Okay.
If the patient says, it only happens early in the morning, right when I wake up, your diagnostic compass should instantly snap to 4 prime suspects.
Well, I'm guessing pregnancy is one, right? The classic morning sickness.
Yes, absolutely. The second is uremia from failing kidneys. Think about it. They've been asleep for 8 hours, not drinking any water.
So the toxins build up.
The toxic waste products have been pooling and concentrating in their blood all night long, reaching a critical threshold by morning. The third suspect is alcoholism.
Why does alcohol cause morning vomiting specifically?
Because a chronic alcoholic's brain relies on the constant depressive effect of the alcohol to stay calm. When they sleep for several hours, their blood alcohol level drops.
Oh, I see.
The brain suddenly wakes up without its depressant shield, goes into a state of hyperexcitability, which is the very beginning of acute withdrawal, and triggers massive morning nausea.
And the fourth morning suspect?
Increased intracranial pressure. And this goes back to basic gravity. When you're standing up during the day, gravity helps pull venous blood down out of your head, keeping the pressure inside your skull relatively low.
But when you lie completely flat for 8 hours to sleep?
That gravitational assist is gone. Venous blood pools slightly in the head. In a healthy person, this is fine. But if you already have a brain tumor or a slow bleed taking up space, that slight pooling of blood overnight increases the pressure inside the skull just enough to severely crush that brainstem vomiting center.
So they wake up, the brainstem is squeezed, and they vomit.
Yes. And terrifyingly, they often vomit violently the second they open their eyes without ever feeling nauseous first. It's purely mechanical pressure, not a chemical sensation.
That is a phenomenal clue. Okay, question 2. We move from the clock on the wall to the clock in their stomach. What is the exact relationship to meals? We are essentially tracking the speed of the plumbing here.
Precisely. The stopwatch starts the exact second they swallow a bite of food. If they tell you the vomiting occurs almost instantly sometimes while they are still chewing their food, definitively the food hasn't had time to reach the stomach.
It hit a wall in the esophagus.
Yes. Which points back to that structural esophageal issue, an obstructing tumor or severe inflammation.
What if there's a delay?
If the vomiting occurs roughly 30 to 60 minutes after eating, the food has successfully traversed the esophagus and is now actively sitting in the stomach, mixing with gastric acid. If they vomit now, it strongly points to a gastric origin, most classically peptic ulcer disease.
Explain the physics of why an ulcer reacts exactly at that 30-minute mark.
An ulcer is a raw, open sore in the stomach lining where the protective mucus is eroded away. When you eat, your stomach ramps up its production of highly acidic hydrochloric acid to digest the food.
And it takes about 30 minutes to really build up.
Right. Around the 30 to 60 minute mark, that pool of fresh acid sloshes against the raw nerve endings of the ulcer. The stomach screams in pain, goes into a severe spasm, and violently rejects the contents.
That makes total sense. But what if they say, they eat lunch at noon, feel terrible all afternoon, and then vomit at 5:00 p.m.?
If the vomiting happens several hours after eating, it physically proves the food is trapped. It points to delayed gastric emptying. The stomach is acting like a sealed bag. This could be gastroparesis.
Which means stomach paralysis, right?
Right. And this is incredibly common in long-standing diabetes. High blood sugar acts like a slow poison to nerves over years. It damages the vagus nerve branches that tell the stomach muscles to churn and push food forward.
The muscles simply start working.
Exactly. Alternatively, the delay could be a physical roadblock at the exit door of the stomach, known as a gastric outlet obstruction. This happens when a chronic ulcer near the exit repeatedly heals and tears, building up a massive knot of hard scar tissue that permanently blocks the gateway to the intestines.
So the timing tells us exactly where the roadblock is, which brings us to question 3. As a doctor, you actually have to look in the basin. What does the vomitus look and smell like?
It's vital forensic evidence. If the fluid is clear or yellowish, that is essentially pure gastric acid and mucus. It confirms the origin is the stomach. But if the fluid is green, well, that changes the entire trajectory of the diagnosis.
Because green means bile. Let's unpack the anatomy of why bile is such a massive red flag.
Bile is a dark green digestive fluid produced by your liver, stored in your gallbladder, and used to break down fats. Here is the anatomical key. The bile duct injects this green fluid into your digestive tract after the stomach in the first part of the small intestine, the duodenum.
So if I am throwing up fluid from my stomach, it shouldn't have bile in it because the bile is further down the pipe.
Exactly. The stomach and the intestine are separated by a muscular door called the pyloric valve. Therefore, if there is green bile in the vomit, it physically proves two things. First, the pyloric door is open.
And second,
The blockage must be deep down in the small or large intestine. The pressure has built up so intensely in the lower bowel that it has forced the green bile backwards up through the open pyloric door into the stomach and out the mouth. Green vomit is the hallmark of an intestinal obstruction.
wow. And it can get worse than bile.
Much worse. If the vomitus is feculent, meaning it literally looks, smells, and has the consistency of liquid stool, that is a catastrophic finding.
Oh, that's terrible.
It means there is a severe, prolonged lower intestinal obstruction. The food has made it down into the large intestine, hit a concrete wall, and sat there for days. Billions of gut bacteria have degraded it into fecal matter.
And it has nowhere to go but up.
And the pressure has become so absolute that this fecal matter has reversed course, traveling all the way back up miles of intestine through the stomach and out the mouth.
That is a nightmare scenario. I assume that means the bowel is dangerously close to bursting.
It is imminent. A feculent vomit can also indicate a gastrocolic fistula. If a severe colon cancer grows aggressively, it can literally bore a hole through the colon wall directly into the adjacent stomach wall, creating a shortcut tunnel. Stool flows directly from the colon into the stomach.
Okay, let's pivot to the most alarming visual of all. Blood. Hematomesis.
Vomiting blood immediately triages the patient to the highest acuity level. But the type of blood tells you a story. If the patient is vomiting dark, granular material that looks exactly like wet coffee grounds, they have an upper GI bleed that has been sitting in the stomach for a little while.
Why does it look like coffee grounds instead of red blood?
Because of chemistry. Blood contains hemoglobin, and hemoglobin contains iron. When fresh red blood hits the highly acidic environment of the stomach, the hydrochloric acid rapidly oxidizes the iron, turning the blood dark brown and clumpy.
It's essentially digested blood.
Right. This often points to a slow, oozing, bleeding peptic ulcer.
And if the blood is bright red,
Bright red blood means massive, active, ongoing hemorrhage. The blood is rushing out so fast the stomach acid doesn't have time to oxidize it.
like a ruptured ulcer.
Yes. Or it could be esophageal varices, which are severely swollen, fragile, varicose veins in the esophagus that occur when liver cirrhosis causes blood pressure to back up into the throat. If one of those veins pops, a patient can bleed to death in minutes.
And the sources also mention a Mallory-Weiss tear. What is the physics behind that?
A Mallory-Weiss tear is fascinating because the vomiting isn't the symptom of the tear. The vomiting actually causes the tear.
Wait, really?
Yeah. If a patient is retching violently and continuously, say, after a massive binge drinking episode, the sheer mechanical, explosive force of the stomach muscles contracting against a closed esophagus creates immense shear stress.
The tissue just gives away.
It literally rips open right at the junction where the esophagus meets the stomach.
Yeah.
It's a longitudinal laceration caused purely by the physics of heaving.
So you interrogate the color. Now we need to look at the pain sequence. Question 4. Did the severe abdominal pain start before the vomiting or after the vomiting?
This is one of the most elegant, simple rules in emergency medicine. In deadly, acute surgical abdomens like a strangulated, dying intestine or an inflamed appendix ready to burst, the pain almost always comes first.
The local issue sets off the systemic alarm.
Exactly. The body senses the local tissue dying or the massive bacterial inflammation. The local nerves scream in agony, and then the systemic reflex kicks in and triggers the vomiting. The localized damage drives the systemic response.
But what if the sequence is reversed? Like, what if the patient says, I was in agonizing pain, but then I threw up, and suddenly the pain felt much better for an hour?
If the pain is relieved by vomiting, you are almost certainly looking at a peptic ulcer. Think of the mechanics. The raw, open ulcer is being bathed in a pool of highly acidic gastric juice, It's like pouring battery acid on a cut.
It burns terribly.
When the patient vomits, they expel all that acid out of the stomach. The ulcer is suddenly dry. The pain temporarily vanishes until the stomach secretes a fresh batch of acid an hour later.
It makes perfect mechanical sense. Okay, question 5. What are the specific associated symptoms? Like, what other alarms are ringing in the body?
This helps us nail down those systemic masqueraders. If the vomiting is paired with a thunderclap headache, stiff neck, or severe vertigo, you ignore the stomach completely.
You look at the brain.
Your diagnostic compass points straight at the central nervous system. You are looking at meningitis infecting the brain lining or a subarachnoid hemorrhage bleeding into the skull space.
What if the vomiting is associated with chest pressure or pain radiating down the left arm?
You order an ECG instantly. As we discussed earlier, the vagus nerve is confusing the signals. The patient's inferior heart wall is suffocating from a blocked artery, and the brain thinks it's a stomach ache. You must rule out an acute coronary syndrome.
And what if we look lower down? What about their bowel habits?
The associated bowel habit is a massive clue. If the patient has violent vomiting paired with obstipation, which is the absolute total inability to pass stool or even pass a single bubble of gas, you have the hallmark triad of a mechanical bowel obstruction.
The pipe is hermetically sealed.
Nothing is getting past the concrete wall of the obstruction.
Contrast that with severe diarrhea.
If they are vomiting from the top and experiencing profuse diarrhea from the bottom, the entire digestive tube is inflamed and trying to purge itself. This is classic gastroenteritis.
Or something chronic.
Right, it could be an inflammatory bowel disease flare-up, like Crohn's disease, where the immune system is aggressively attacking the gut lining, causing it to secrete massive amounts of fluid instead of absorbing it.
And finally, question 6. What medications or toxins are actively in the patient's system? We briefly touched on digoxin, but what are the other common culprits?
You must do a relentless medication reconciliation. Are they taking large daily doses of NSAIDs, like ibuprofen, naproxen, or aspirin for chronic joint pain?
Let's actually pause there because so many people pop ibuprofen like candy. How exactly do NSAIDs trigger vomiting?
It's all about prostaglandins. NSAIDs work by blocking an enzyme called cyclooxygenase, which produces prostaglandins. Those are the chemicals that cause inflammation and pain in your swollen knee.
Okay, so it stops the knee pain.
But here's the catch. In the stomach, prostaglandins have a completely different job. They are responsible for telling the stomach lining to secrete a thick layer of protective alkaline mucus.
Oh, wow. So if you take an NSAID to stop the pain in your knee, you accidentally turn off the machine that builds the protective mucus shield in your stomach.
Exactly. The mucus shield dissolves. Now, the stomach's own hydrochloric acid starts actively eating away at the unprotected stomach wall, causing severe gastritis, forming deep ulcers, and triggering violent pain and vomiting. It is a direct chemical consequence of the drug's mechanism.
That is a brilliant explanation. So by asking just 6 targeted questions, timing, meals, appearance, pain sequence, associated symptoms, and meds, you've taken a chaotic, vague symptom and narrowed it down to 2 or 3 prime suspects.
You really have.
But the patient's story is still subjective. We need to physically verify it.
Which brings us to step 3 of the algorithm, which is the targeted physical examination. We move from their story to the objective clues their body is hiding in plain sight. And we never touch the abdomen until we have checked the vital signs. We are assessing the ABC's airway, breathing, circulation, and specifically hunting for the clinical signs of shock.
If I have been throwing up for 3 days, my body is obviously dehydrated, but how does a simple blood pressure cuff and heart rate monitor tell you if I'm in actual danger?
They tell us how close the system is to crashing. If we see hypotension, a dangerously low blood pressure, say 80/50, coupled with severe tachycardia, a heart rate of 130 beats per minute, the body is screaming that it is in a state of hypovolemic shock.
So the heart is beating frantically fast because it's desperately trying to pump what little fluid volume is left in the pipes just to keep the brain oxygenated.
Exactly. The pump is overworking to compensate for the empty pipes. This could simply be massive fluid loss from the vomiting itself, but it could also indicate something far more sinister.
Like internal bleeding.
Right, massive internal bleeding from a ruptured varus, or systemic septic shock from a burst appendix, where bacterial toxins have caused all the blood vessels in the body to dilate and leak, dropping the pressure to the floor.
The sources mention a very specific test for autonomic neuropathy called orthostatic blood pressure. How does that work, and what does it prove?
This is a beautiful piece of bedside physiology. You take the patient's blood pressure and heart rate while they have been lying flat on their back for a few minutes. Then you have them stand up quickly, and you immediately measure the vitals again.
In a healthy person, gravity is going to try to pull all the blood down into their legs when they stand.
Right. And your autonomic nervous system instantly detects that gravitational drop in pressure and fires a signal to the heart, telling it to beat 15 or 20 beats faster to pump the blood back up to the brain. You might feel dizzy for half a second, but your heart rate spikes to fix it.
But what if they have autonomic neuropathy from severe diabetes?
If those autonomic nerves are fried by years of high blood sugar, the reflex is broken. You stand the patient up, gravity pulls the blood to their legs, their blood pressure plummets dangerously, but their heart rate stays exactly the same. The heart never gets the signal to speed up.
And if their autonomic nerves are too damaged to regulate their heart, it heavily implies those same nerves are too damaged to tell their stomach to empty.
Perfectly stated. It is a brilliant, non-invasive way to confirm a diagnosis of diabetic gastroparesis as the underlying cause of the vomiting.
We also have to look at how they are breathing, right? Tachypnea.
Rapid, deep breathing. If a patient is vomiting and taking deep, rapid breaths, often called Kussmaul respirations, they are not out of breath from running a marathon. They are in a state of severe metabolic acidosis.
Explain that metabolic trick. Why does acidic blood make you hyperventilate?
Because your lungs are the fastest acid removal system in your body. If your blood is filling with keto acids from diabetic DKA or lactic acid from a dying, strangulated intestine, the pH drops. The brain detects this acid and commands the lungs to hyperventilate.
I see.
Every time you exhale deeply, you blow off carbon dioxide. And in the bloodstream, carbon dioxide acts as an acid.
So by panting like a dog, they're literally exhaling the acid to keep the blood pH from becoming lethal.
Yes, it's a respiratory compensation for metabolic disaster. If you see it, the patient is incredibly sick.
Okay, vitals are stable, or at least we understand them. Now we perform the main event, the abdominal exam.
And crucially, you listen before you touch. Auscultation. You place your stethoscope on the abdomen to listen to the bowel sounds. You don't want pressed down first, because pressing can artificially stimulate the bowel to contract and give you a false reading.
What exactly are we listening for? Like, what does an obstruction sound like?
If the bowel is mechanically blocked by a tumor or scar tissue, the intestines behind the blockage don't just give up immediately, they fight.
They try to push through it.
They contract violently, trying to force fluid and trapped gas through a pinpoint opening under massive pressure. Through the stethoscope, this sounds like hyperactive, high-pitched metallic tinkling. It sounds exactly like water rushing through a narrow, kinked garden hose under high pressure.
The plumbing is actively fighting the block, and what if you put the stethoscope down and hear absolute silence?
A completely silent abdomen, absent bowel sounds for several minutes is an ominous sign. It means the bowel has essentially paralyzed itself. This is called a paralytic ileus.
Why would the bowel just freeze?
It is a defensive reflex against severe diffuse peritonitis. If an ulcer or an appendix has ruptured and spilled billions of bacteria and toxic acid all over the outside of the intestines, inflaming the peritoneal lining of the entire abdominal cavity, the nervous system shuts down all intestinal movement to prevent spreading the infection further.
The bowel goes perfectly still.
Exactly.
Now here is a physical maneuver from the sources that sounds almost beautifully medieval. The succussion splash. For the listener trying to visualize this, what exactly is the doctor doing, and how does it prove the stomach is blocked?
It is an old-school, highly effective clinical test. Imagine a half-filled water balloon. If you shake it, you hear it slosh. The human stomach is essentially a muscular balloon.
Right.
Normally, if you eat a meal and drink a glass of water, your stomach churns it up and empties it all into the intestines within a couple of hours.
So if you shake a normal person 3 hours after lunch, they shouldn't slosh.
Right. But if a patient has a severe gastric outlet obstruction, say, a massive tumor blocking the exit valve or completely paralyzed gastroparesis, all that fluid, acid, and undigested food is trapped in the stomach bag. It has nowhere to go.
So what do?
You place your stethoscope over their upper abdomen, you physically grasp the patient by the hips, and you gently but firmly rock them back and forth from side to side.
You physically slosh the patient.
Literally. And if you hear a loud, distinct splashing sound through the stethoscope 3, 4, or 5 hours after a last meal, you have definitive physical proof that the stomach is failing to empty. The lake is dammed up.
That is amazing. So simple, but irrefutable. Okay, after listening and sloshing, you finally press on the abdomen. Palpation.
Yes, and we are hunting for localized pain to pinpoint the exact organ failing. We look for specific eponymous signs. First, you press your fingers deep under the right rib cage, right where the liver and gallbladder sit, and you ask the patient to take a deep breath.
What does the deep breath do?
As they inhale, their diaphragm pushes their liver and gallbladder downward right into your waiting fingers. If their gallbladder is severely infected and inflamed acute cholecystitis, the moment the inflamed organ touches your fingers, the pain is so sharp they will suddenly gasp and catch their breath.
Just a sudden stop in breathing?
Yes, that sudden cessation of inspiration is a positive Murphy's sign.
It's an anatomical trap. What else?
You check for Robsing's sign to find appendicitis. The appendix is located in the bottom right corner of your abdomen, the right lower quadrant. But to test it, you press deep and hard into the left lower quadrant.
Wait, why would pressing on the left side of the body cause pain in an organ on the right side of the body?
It's an indirect pressure test based on the shape of the large intestine. The large intestine is an archway. By pressing deeply on the descending colon on the left, you are physically pushing trapped intestinal gas backward, up and over the arch, increasing the pressure in the cecum on the right side.
Oh, I see.
That sudden stretch of the cecum pulls directly on the inflamed appendix attached to it, causing a spike of pain on the right side.
That is an incredibly clever mechanical trick. And then there's rebound tenderness.
Rebound tenderness is the hallmark of peritonitis. You press your hand slowly and deeply into the abdomen, which hurts a little, but then you suddenly and violently rip your hand away.
And the sudden release hurts worse than the pressure.
Exactly. When you let go, the inflamed peritoneal lining of the abdomen snaps back into place like a rubber band. If it's infected with bacterial pus from a ruptured viscus, that sudden snapping friction causes excruciating agony. It is a massive red flag for a surgical emergency.
Okay, wow.
And finally, before you finish the physical exam, you must systematically check the hernial orifices in the groin and the umbilicus.
Because a hernia isn't just a bulge.
No, a hernia is a defect, a physical hole in the strong fascial wall of the abdomen. If the pressure inside the belly spikes, say, from heavy lifting or a coughing fit, a tiny loop of the small intestine can pop out through that hole and get trapped.
It gets pinched.
Yes, the tight ring of the hernia clamps down on the bowel like a snare, completely cutting off its blood supply. It becomes a strangulated hernia, causing a massive, lethal bowel obstruction and violent vomiting, all from a lump in the groin that is easily missed if you don't pull the blanket back and look.
So we've exhausted the abdomen. But the expert diagnostician doesn't stop there. The sources emphasize looking for weird systemic clues scattered across the rest of the body. You have to act like a forensic pathologist on a living patient. Where do you look?
You start at the face and the mouth. You look closely at their teeth. If you see severe erosion and dissolution of the hard dental enamel, particularly on the lingual surface, the back of the front teeth, you are looking at chemical burns.
From the stomach acid.
Exactly. Gastric hydrochloric acid is incredibly caustic. If the teeth are worn down, it proves the patient has been subjected to severe chronic acid exposure for months or years.
Which points to what?
This strongly points to a severe anatomical reflux disease, or, very frequently, a hidden eating disorder like chronic bulimia nervosa. The physical wear on the teeth betrays the secret history of the vomiting.
What about the skin on the face? I'm fascinated by this mask phenomenon.
The mask phenomenon is a physical testament to the sheer violence of the vomiting reflex. If you look at the patient's face, around their eyes and on their upper neck, you might see hundreds of tiny, pinhead-sized red or purple dots called petechiae or purpura.
Those are burst blood vessels, right? How does throwing up burst blood vessels in your eyelids?
It is the physics of the Valsalva maneuver. When a patient retches with immense convulsive force, the glottis in their throat snaps shut while their diaphragm violently thrusts upward. This causes the intrathoracic pressure, the pressure inside the chest cavity, to spike to astronomical levels.
And that pressure has to go somewhere.
It transmits backward up the jugular veins, directly into the venous system of the head and face. The microscopic capillary blood vessels and the delicate skin of the eyelids simply cannot withstand the sudden spike in hydraulic pressure, and they literally burst, leaking tiny drops of blood under the skin. It tells you the patient has been heaving with dangerous force.
Wow. And then we check the eyes themselves.
You look at the sclera, the white part of the eye. If it has a distinct yellow tint scleral icterus, you have found clinical jaundice.
Which means a liver problem.
This immediately pivots your entire diagnostic algorithm away from the stomach and directly toward the liver and biliary tree. It means bilirubin is building up in the blood, pointing to acute hepatitis or gallstone blocking the common bile duct.
And if you use that little flashlight tool, the ophthalmoscope, to look through the pupil at the back of the eye.
You are looking directly at the optic disc. the head of the optic nerve where it enters the eye from the brain. If that disc is swollen, engorged, and its borders are blurry, a condition called papilledema, you have found physical, visual proof of increased intracranial pressure.
The brain is swelling.
The brain is swelling, the pressure is squeezing the optic nerve, and the vomiting is purely neurological.
It is an entirely holistic investigation. The teeth, the burst capillaries, the yellow eyes, the swollen nerves. But eventually, human observation hits its limits. We need hard, objective data to prove our theories. This brings us to step 4 of the algorithm, the investigative arsenal, labs and imaging.
We are moving from clinical suspicion to objective molecular proof. And this phase of the algorithm begins with one absolute, non-negotiable, universally mandated test.
Let me guess, it's the pregnancy test.
For any female patient of childbearing age presenting with nausea, vomiting, or abdominal pain, a serum human chorionic gonadotropin and HCG test is absolutely mandatory.
But what if she says she hasn't been sexually active? Or what if she's on an IUD?
It does not matter. The clinical guidelines are ruthlessly explicit on this. You must run the test. Because you are not just ruling out morning sickness, you are ruling out a ruptured ectopic pregnancy.
Oh, wow.
If a fertilized egg implants in the narrow fallopian tube instead of the uterus, it will eventually grow too large and rupture the tube, severing major arteries. An ectopic pregnancy can present primarily with abdominal pain and vomiting, and if you miss it, the patient can bleed to death internally in a matter of hours. It is the very first box you check to protect the patient's life.
Okay, the HCG is sent. What other blood work are we drawing? The sources talk about the blood acting like a flight data recorder.
That is a perfect analogy. The biochemical state of the blood tells you exactly what kind of trauma the body has endured over the last 48 hours. Let's look at the classic vomiting signature.
Show me how to read the chemical data.
When a patient vomits profusely for days, they're actively losing massive quantities of gastric fluid. That fluid contains 2 vital components, hydrochloric acid and large amounts of potassium.
So they are losing acid.
As the body loses all that acid out the mouth, the pH of the blood naturally begins to rise. The blood becomes excessively basic, or alkaline.
Okay, so we have metabolic alkalosis from throwing up acid, but what happens to the potassium?
That's where the kidneys make things worse. The body senses the severe dehydration from vomiting. The brain panics and activates a hormone system called the renin-angiotensin-aldosterone system. The hormone aldosterone screams at the kidneys, "Save water and sodium at all costs."
Because sodium holds on to water, keeping the blood volume up.
Right. But the kidneys operate on an exchange system. To pull a sodium ion back into the blood, they have to throw a potassium ion out into the urine. So the patient is losing potassium from throwing up, and they're losing massive amounts of potassium from their kidneys, desperately trying to save water.
So when the lab results hit your screen, what do you see?
You see the undeniable signature. Severe hypokalemia, dangerously low potassium, coupled with volume contraction metabolic alkalosis. If you see that specific chemical pairing, you know mathematically that the patient has been losing massive amounts of fluid, specifically from the upper GI tract.
But what if the flight data recorder shows the exact opposite? What if the blood isn't basic, but highly acidic?
Then you are looking at the ischemia signature, and it should ring every single alarm bell in the ER. If the lab shows a high anion gap metabolic acidosis in a vomiting patient, the narrative completely changes.
What does a gap acidosis actually mean at a cellular level?
It means that the blood isn't just failing to clear normal daily acids. A massive amount of new, toxic, unmeasured acid is actively being produced inside the patient's body in real time.
Produced by what?
By dying tissue. If a loop of intestine is trapped in a hernia, its blood supply is choked off. The cells are suffocated without oxygen.
So they switch how they make energy.
Right. To survive a few minutes longer, those cells switch to anaerobic metabolism, which burns fuel without oxygen. The toxic byproduct of this emergency mechanism is lactic acid. As the bowel dies, it turns out massive amounts of lactic acid into the bloodstream, dropping the pH and creating that gap acidosis.
So the blood literally tells you if tissue is currently dying and turning black inside the abdomen.
Yes. Alternatively, if the patient is in DKA, their liver is churning out massive amounts of keto acids. A gap acidosis means you are moving away from a simple hydration problem and stepping into an immediate, life and death, metabolic, or surgical crisis.
That is incredible. What other labs help us pinpoint the organ?
You look at the BUN to creatinine ratio. BUN stands for blood urea nitrogen. Both are waste products cleared by the kidneys.
What are we looking for there?
If the BUN level spikes massively while the creatinine stays relatively stable, it usually points to profound dehydration. But it can also act as a clever biochemical trick to detect a hidden, massive GI bleed.
Wait, how does bleeding into your stomach cause a spike in nitrogen in your blood?
Because whole blood is incredibly rich in protein. If an ulcer ruptures and you bleed a liter of blood into your own stomach and intestines, your digestive system simply treats it like you just ate a massive raw steak.
It digests the blood proteins.
Yes, it breaks them down into urea and absorbs them back into the bloodstream, causing the blood urea nitrogen to spike artificially high. It's the body recycling its own hemorrhage.
Wow. Next.
Amylase and lipase. These are the specific digestive enzymes manufactured by the exocrine cells of the pancreas. Amylase breaks down carbs, lipase breaks down fats. They belong inside the gut tube.
So if they are in the blood,
If the blood lab shows these enzymes are markedly elevated, often 3 times the upper limit of normal form, it means the pancreatic cells are actively bursting and spilling their contents directly into the blood. It is highly diagnostic for acute pancreatitis.
and the liver.
We check the liver function tests, AST, ALT, and bilirubin. AST and ALT are metabolic enzymes that live safely inside healthy hepatocytes, the liver cells.
So they shouldn't be high in the blood either.
Right. If the liver is infected with hepatitis or poisoned by an overdose of Tylenol, those hepatocytes swell and die, bursting open and leaking AST and ALT to the circulation. Spiking liver enzymes means the liver is actively taking damage. And finally, if the history points to it, we run specific toxicological assays to measure the exact blood concentration of drugs like digoxin or salicylates.
Okay, so the blood work gives us the biochemical map. We know what is failing, but we don't necessarily know exactly where it is failing. We need the geographical map. We need imaging.
Precisely. If the history and physical exam heavily suggest a mechanical plumbing issue and obstruction, the first line of imaging is plain abdominal x-rays. And the protocol insists on taking views with the patient both standing erect and lying supine flat on their back.
Why do you need both positions? What are we looking for in the shadows?
We are tracking the behavior of gas and fluid. In a healthy abdomen, a little bit of gas is scattered safely throughout the intestines. But if there's a concrete blockage, gas and fluid back up.
What does that look like?
On the supine film lying flat, you will see massively dilated, swirling loops of bowel stretching across the abdomen, looking like stacked sausages.
And when they stand up?
Gravity takes over. The heavy fluid pools at the bottom of the intestinal loops and the lighter gas rises to the top. On the erect X-ray, you will see distinct air fluid levels. They look like straight, horizontal lines where the liquid settles, with black domes of gas sitting on top of them, stacked up like a stepladder across the film. It is the classic radiological proof of a bowel obstruction.
Are there specific shapes or patterns to look for? The sources highlighted a couple of vivid names.
Yes, there are eponymous shapes that tell you the exact mechanism of the twist. For example, if the cecum, the highly mobile beginning of the large intestine, twists violently around its own vascular stalk, a condition called a cecal volvulus, it acts like a pinched-off balloon. Gas continues to flow in, but it can't get out.
So it inflates massively.
It inflates to terrifying proportions. On the X-ray, this massive twisted loop of bowel forms a huge dark oval with a white line down the middle where the inner walls touch. It looks exactly like a gigantic coffee bean, and it typically points up toward the left upper quadrant of the abdomen. It is famously called the coffee bean sign.
And the bird beak sign.
The bird beak sign is visualized when you use a contrast study. You have the patient drink a chalky, radio-opaque liquid like barium, or you administer it via enema.
Okay, so it shows up bright white on the scan.
Right. As the bright white dye flows through the dark bowel on the X-ray, it hits the exact point where the intestine is violently twisted shut. The thick column of dye tapers down sharply into a tight, pointed cone, looking exactly like a bird's beak. It pinpoints the exact millimeter where the surgeon needs to cut to untwist the torsion.
But wait, you said arguably the most critical thing to look for on an erect X-ray isn't in the intestines at all. It's up by the lungs.
Yes. On an erect chest or upper abdominal X-ray, the most terrifying finding is a crescent of free radiolucent air trapped right under the diaphragm muscle.
Why is air under the diaphragm an absolute disaster?
Because the laws of anatomy state that gas belongs inside the digestive plumbing. The space outside the intestine, the peritoneal cavity, should be completely free of air.
So if there's air floating up?
If you see gas floating up and hitting the roof of the abdomen under the diaphragm, it physically proves that there is a hole in the plumbing. A viscus is perforated. A peptic ulcer has eaten entirely through the stomach wall, or a swollen appendix has burst. Gas and toxic contents have escaped into the free cavity. It is an unquestionable rush to the operating room emergency.
But X-rays are fundamentally 19th century technology, right? They're just 2D shadows superimposed on each other.
Exactly. They have severe limitations. If the X-rays are ambiguous, which they often are, or if the patient is too sick to stand up for the erect film, you move to the absolute gold standard, the CT scan of the abdomen and pelvis.
That gives you the 3D view.
A CT scan takes thousands of cross-sectional slices. It provides a high-resolution, three-dimensional roadmap. It will definitively localize the exact millimeter of a bowel obstruction, visualize hidden tumors, show the inflamed fat stranding around a diseased pancreas, and peer deep into the retroperitoneal space where X-rays cannot see.
And what if the problem is higher up? Say, a bleeding ulcer or a Mallory Weiss tear in the esophagus. A CT scan can't easily see a surface scratch on the inside of the stomach tube.
For the upper GI tract, you bypass shadows and scanners entirely. You need a camera. You need upper gastrointestinal endoscopy, or UGIE.
Down the throat.
Right, a gastroenterologist passes a flexible optic tube with a camera down the throat of the sedated patient. It is the gold standard for directly visualizing peptic ulcer disease, spotting the exact bleeding varicose vein, or confirming the tear. You aren't guessing based on shadows. You are looking at the bleeding tissue in high-definition real-time, and you can intervene with tools right through the camera.
Okay, let's take stock. We have interrogated the patient with our history algorithm. We have read the body's hidden clues during the physical exam. We have decoded the biochemical flight data recorder in the blood, and we have built a three-dimensional radiological map. We know exactly what is wrong. Now, we arrive at the culmination of this entire deep dive. Step 5, the ER treatment algorithm. We are moving from diagnosis to actual dosing. How do we stabilize and treat this patient right now?
And this is where the precision matters. Everything starts with immediate resuscitation. Before you can cure the underlying disease, you have to ensure the biological machine doesn't shut down. If the patient's vital signs showed shock, the tachycardia, the hypotension, the altered mental status, you immediately establish large-bore IV access and begin aggressive fluid resuscitation.
What exactly are we pumping into their veins?
The standard is an isotonic crystalloid solution, specifically 0.9% sodium chloride, also known as normal saline. It has a similar osmotic pressure to human blood.
Okay, so just refilling the tank.
You are rapidly expanding the intravascular volume so the heart has actual fluid to pump, restoring blood pressure and oxygen delivery to the dying tissues. Simultaneously, you must correct the severe electrolyte imbalances we found in the labs. You meticulously replace the depleted potassium via an IV drip to prevent the heart from slipping into a lethal, chaotic arrhythmia.
What if our imaging showed a massive physical blockage, like the coffee bean volvulus or a swollen, paralyzed stomach?
If there's any clinical or radiological sign of a mechanical bowel obstruction or severe gastric outlet obstruction, giving fluids isn't enough. You must immediately decompress the system. You insert a nasogastric tube, an NGT.
Explain the physics of how that helps.
You lubricate a long, flexible plastic tube, pass it through the patient's nostril, down the back of the throat, through the esophagus, and rest the tip deep inside the stomach lake. You then connect the outside end of the tube to a wall-mounted vacuum suction unit.
And it just pumps it out.
It actively, continuously pumps out the trapped gas, the liters of backed-up acidic fluid, and the bilious sludge.
It's literally draining the swamp.
Yes. It instantly relieves the agonizing distension, stretching the stomach wall, stops the persistent vomiting, and critically prevents the exhausted patient from accidentally inhaling their own vomit into their lungs, which causes fatal aspiration pneumonia.
Okay, the fluid is running, the stomach is decompressed, but the patient is still horribly nauseous. They are suffering. Let's talk about the specific pharmacological management for symptom control. What are we giving them, and how does it actually turn off the nausea?
The cornerstone of antiemetic therapy in the ER protocols are the phenothiazines.
How do they work at a molecular level?
They are essentially highly targeted chemical blockers. Once injected or swallowed, these molecules cross the blood-brain barrier. Their principal mode of action is to seek out and bind tightly to the central nervous system. Dopamine receptors, specifically the D2 receptors, located right inside that highly sensitive chemoreceptor trigger zone in the medulla.
So they block the dopamine signals.
By plugging up those receptors, they block the dopamine signals from firing. They literally, chemically, silence the fire alarm in the brain, The brain stops telling the stomach to heave.
Can you give us the specific medications and the exact protocol dosages from the sources? Like, how do you choose which one to use?
Absolutely. The three most commonly deployed agents in this class are prochlorperazine, chlorpromazine, and promethazine.
Okay, let's go through them.
For prochlorperazine, widely known as Compazine, the standard dose is 10 milligrams taken orally every 4 to 6 hours, based on its half-life in the liver. However, if the patient is vomiting so violently they cannot keep a pill down, you bypass the stomach entirely.
Meaning a suppository.
You administer a 25 milligram suppository per rectum, where the drug absorbs directly through the mucosal lining into the bloodstream. For chlorpromazine, or Thorazine, the protocol dictates 25 milligrams orally every 8 hours.
And promethazine.
And for promethazine, known as Phenergan, the dosing is highly versatile, 12.5 to 25 milligrams. It can be administered orally, per rectum, or via a deep intramuscular injection every 6 to 12 hours, depending on symptom severity.
Wait, hang on. Dopamine isn't just the nausea chemical. Dopamine is the primary neurotransmitter that allows the brain's basal ganglia to coordinate smooth, voluntary muscle movement.
Oh, yes.
If we are blasting the brain with heavy dopamine blockers to stop the vomiting, aren't we risking massive collateral damage to their movement control?
That is a brilliant and absolutely critical observation. Blocking dopamine is incredibly effective for nausea, but it is a dangerous physiological trade-off. By blocking D2 receptors, these phenothiazines can accidentally trigger what are called extrapyramidal side effects.
What does that actually look like in the ER bed?
It is terrifying for the patient and their family. Because the basal ganglia's dopamine supply is suddenly cut off, the patient can develop acute dystonia. This manifests as severe, agonizing, completely involuntary muscle spasms.
Oh, wow.
Their jaw might lock tight. Their neck muscles might spasm violently, twisting their head to the side. Their eyes might involuntarily roll up to the top of their head and lock there. To a layperson, it looks exactly like they're having a stroke or a bizarre seizure.
That sounds like a horrific trade-off. How do you fix a chemical stroke that you accidentally caused?
You have to instantly restore the neurochemical balance. In the basal ganglia, dopamine acts like a brake, and another chemical called acetylcholine acts like the gas pedal for muscle contraction.
So if you blocked the brake...
Since you blocked the dopamine brake, the acetylcholine gas pedal is floored, causing the spasms. So you must immediately administer an anticholinergic medication to block the acetylcholine and restore the balance.
What are the specific rescue drugs and doses for that?
The primary protocol is to administer benztropine, known as Cogentin, at an exact dose of 2 milligrams intravenously. It hits the brain instantly. Alternatively, you can use diphenhydramine, which is common Benadryl, at a dose of 25 milligrams either intravenously or via intramuscular injection, repeated every 4 to 6 hours.
Does it work quickly?
Within minutes of the injection, the terrible spasms dissolve, the muscles relax, and the patient is back to normal. It is a very dramatic pharmacological save.
Okay, so we've covered the general fluid resuscitation and the precise symptom control. But the sources provide highly specific, targeted treatment pathways for the major life-threatening emergencies we identified earlier. Let's walk through the targeted pathway for peptic ulcer disease resulting in active gastrointestinal bleeding, hematemesis.
If the patient is vomiting bright red blood, the stakes are maximal. The very first step is establishing 2 large-bore IV lines. You need massive pipes into the veins because you need to be able to push huge volumes of fluid or actual packed red blood cells rapidly to replace what they are losing.
Okay, that makes sense.
However, the advanced protocols contain a fascinating and crucial caveat. Give blood transfusions carefully.
Why carefully? If they have a hole in their artery and they are bleeding out, shouldn't you just pump them full of fresh blood as fast as possible to keep the tank full?
Intuition says yes, but physiology says no. The guideline explicitly states, do not overtransfuse a stable patient. If you rapidly pump their blood pressure back up to normal levels, the increased hydrostatic pressure inside the blood vessels will act like a power washer.
Oh, no.
It will literally blow the fragile, life-saving fibrin clot right off the bleeding ulcer, and they will hemorrhage catastrophically all over again.
Oh, wow. So you want their blood pressure just low enough that they don't die, but not so high that you blow the seal.
Exactly. It's called permissive hypotension. You transfuse just enough to maintain a safe minimum hemoglobin level, usually around 7 grams per deciliter, not to make them completely normal.
There's a phenomenal nuance. Okay, what is the medical pharmacological intervention while the gastroenterologist is rushing down the hall to run the endoscopy camera?
We deploy a massive PPI protocol. PPI stands for proton pump inhibitor. These are drugs that bind directly to the parietal cells in the stomach lining and completely shut down the microscopic molecular pumps that secrete hydrochloric acid.
What's the dose?
Initially, you administer omeprazole 40 milligrams intravenously twice a day while awaiting the endoscopy.
And what if the endoscopist gets the camera down into the stomach and finds a massive, aggressively spurting arterial bleed in the base of a deep ulcer?
Then you hit them with the pharmacological heavy artillery. You administer a massive, high-dose intravenous PPI regimen. You push an 80 milligram stat injection instantly into the vein, followed seamlessly by a continuous IV infusion, dripping at precisely 8 milligrams per hour for the next 72 hours continuously.
Okay, I have to stop you again because this doesn't make intuitive sense. An 80 milligram stat IV push, followed by a 72-hour continuous drip, is a staggering, overwhelming amount of acid suppression.
It really is.
Why is shutting down stomach acid so immediately critical when the primary issue is bleeding? We aren't trying to cure heartburn here, we are trying to stop a hemorrhage. How does turning off acid stop bleeding?
It doesn't stop the bleeding directly. It is entirely about protecting the clot. When an artery tears, the body rushes platelets to the site to form a plug and then weaves a strong mesh-like protein called fibrin over it to seal the hole.
Right, the clot.
That the fibrin clot is the only thing keeping the patient alive. But here is the massive physiological problem. The stomach is a hostile environment. It is filled with hydrochloric acid and a highly active, aggressive digestive enzyme called pepsin. Its sole biological purpose is to dissolve and digest proteins like a pair of chemical scissors.
And the life-saving blood clot is made of protein.
Exactly. If the pH of the stomach remains acidic, below a pH of roughly 5.0, pepsin is highly active. It'll literally digest and dissolve the body's own life-saving blood clot exactly as fast as the body forms it.
Yeah.
The bleeding will never, ever stop. The patient will bleed to death while their own stomach digests the cure.
That is horrifying.
So by administering that massive 72-hour continuous PPI infusion, you artificially raise the pH of the entire stomach to a neutral, non-acidic state, usually around a pH of 6 or 7. At a neutral pH, the pepsin enzyme is completely paralyzed and permanently denatured. The chemical scissors are broken.
That is amazing.
This provides a perfectly safe, non-acidic, non-digestive environment for the delicate fibrin clot to stabilize, mature, harden, and permanently seal the artery wall. You are literally generating a chemical force field around the clot to buy the artery time to heal.
That is absolutely brilliant. It's a manipulation of the organ's native environment to protect the body's natural healing mechanics. Okay, let's look at the next targeted pathway from the sources. Gastric outlet obstruction and perforation.
Let's isolate gastric outlet obstruction first. This is the scenario where the stomach is functionally full, but the pyloric exit door into the intestine is severely scarred shut from years of healing ulcers or physically blocked by a large mass.
So the stomach just fills up.
The stomach is massively dilated, acting like an oversold balloon and vomiting everything back up.
How do you fix a door that's welded shut?
The initial treatment is strict conservative management. First, the patient is made NPO absolutely nothing by mouth. Not a cracker, not a sip of water. Second, you place the continuous nasogastric tube to pump the stomach completely dry, relieving the immense stretch on the stomach wall.
And then?
Third, massive 5E fluids to rehydrate and IV PPIs to chemically turn off the stomach's acid production. Reducing the sheer volume of fluid the stomach is adding to the problem. You are essentially putting the stomach in a medically induced coma to rest it.
But what if resting it doesn't fix the physical scar tissue blocking the door?
If conservative management fails over a few days, you have to physically force the door open. This starts with endoscopy. The doctor passes a deflated heavy-duty medical balloon down the camera tube, threads it directly through the tightly narrowed stricture, and then powerfully inflates it under high pneumatic pressure.
Oh, wow.
This literally rips and stretches the thick scar tissue open, a procedure called balloon dilatation.
And if the balloon doesn't work, if the scarring is just too thick?
Then it requires definitive surgical plumbing redesign. The surgeon might perform a pyloroplasty, which involves physically cutting the exit valve open horizontally and sewing it closed vertically to permanently widen the channel. Or, if it's a massive tumor, they might perform a gastroenterostomy.
What does that entail?
They leave the blocked door exactly where it is, cut an entirely new hole in the bottom of the stomach pouch, bring up a healthy loop of the small intestine, and sew it directly to the new hole. They build an entirely new bypass drain so the food just drops straight down into the gut, avoiding the blockage entirely.
A complete anatomical bypass. And finally, the ultimate nightmare scenario. What is the pathway for a perforated viscus? This is the patient where the X-ray showed the black crescent of free air trapped under the diaphragm.
This is the apex of surgical emergencies. A peptic ulcer, or a diseased intestine, has completely eroded through the organ wall and burst open. The normally pristine, sterile cavity of the abdomen is suddenly being flooded with highly acidic gastric juices, corrosive pancreatic enzymes, and quite literally billions of virulent intestinal bacteria.
The patient must be crashing instantly.
They are entering rapid catastrophic septic shock. The toxic spillage causes the blood vessels to dilate massively, tanking the blood pressure. The initial ER treatment is frantic. Immediate, massive 5E fluid resuscitation through multiple lines just to keep the heart pumping.
And the acid.
You push IV BPIs to try and shut off the acid faucet spilling into the belly. And most critically, you must start broad-spectrum intravenous antibiotics immediately before the surgeon even arrives.
Why broad spectrum? What specific microbiological threats are we fighting in gut spillage?
You are fighting a multi-front bacterial war against billions of organisms. The gut is incredibly diverse. The antibiotics must be chemically designed to penetrate and destroy gram-negative bacilli, like E. coli and Klebsiella.
What makes gram-negative bacteria so dangerous here?
Gram-negative bacteria have a unique double-layered cell wall that makes them highly resistant to older antibiotics like penicillin. Furthermore, their outer membrane contains lipopolysaccharides, which act as potent endotoxins.
Endotoxins.
Yes. When these bacteria die and burst open in the abdomen, they release these endotoxins, which trigger an overwhelming, deadly immune response that accelerates the septic shock.
So you need drugs specifically engineered to pierce that double wall.
Yes, often heavy-duty cephalosporins or carbapenems. You also must cover enterococci, which are tough gram-positive bacteria, and crucially, you must include a drug like metronidazole to kill the anaerobes.
The bacteria that don't need oxygen.
Right, bacteria like bacteroids that thrive deep in the oxygen-deprived muck of the colon and cause massive necrotic abscesses in the abdominal cavity.
It is a chemical carpet bombing of the bloodstream.
It is. But you must understand this fundamental surgical truth. Antibiotics will not cure a hole in the bowel. They only buy you time. The ultimate, absolute, and only definitive treatment is an urgent, lights and sirens referral to the operating room.
The
surgeon must slice the abdomen wide open, physically suction out the liters of toxic infected spillage, aggressively wash the entire peritoneal cavity with liters of warm saline, and physically sew the perforation closed with sutures or resect the dead bowel entirely. If you do not close the hole, the patient will die, regardless of the drugs.
So let's just take a breath and zoom all the way out to recap this incredible physiological journey. We started with what seems like a single, universally common, almost annoying symptom, a patient throwing up into a basin in the ER.
Right.
And we have walked through a highly structured, incredibly elegant, and ruthless algorithm to decode it. We learned how to categorize the immediate threat into surgical emergencies, painful GI conditions, and the sneaky, deadly systemic masqueraders, from the brain-squeezing pressure of a tumor to the vagus nerve confusing a dying heart for a bad stomach.
It's all connected.
We learned how to meticulously interrogate the act of vomiting itself, using the exact timing to find the roadblock, the green color of bile to prove the pyloric door is open, the smell of obstruction, and the precise sequence of pain to differentiate ischemia from an acid burn.
And we learned how to read the body's physical evidence, moving from the vital signs of hypovolemic shock to the Valsalva-induced capillary bursts on the eyelids and the literal sloshing sound of a paralyzed stomach.
We decoded the biochemical flight data recorder of the blood, tracking exactly how the body dumps potassium to save sodium, and how dead tissue leaks lactic acid into the bloodstream to trigger a GAP acidosis.
We used X-rays to spot the massive twisted coffee bean of a volvulus and the catastrophic free air of a burst intestine.
And finally, we detailed the precise molecular-level pharmacological combat. We saw how blocking dopamine stops the heaving but risks chemical strokes, and how a 72-hour massive acid suppression drip acts as a chemical force field to protect a fragile, life-saving blood clot from being digested by the stomach's own enzymes.
It is a powerful reminder that in the high-stakes environment of emergency medicine, absolutely nothing is ever just a simple symptom. Every presentation is a deeply complex, interrelated physiological puzzle. And the algorithm we walk through today provides the precise map to solve it systematically, step by step, leaving absolutely nothing to chance or guesswork.
And I want to leave you, the listener, with a final provocative thought to mull over. We spend this entire time, our entire lives, really viewing vomiting primarily as a chaotic, embarrassing, distressing, and unpleasant illness. We view it as a breakdown of the system.
That's right.
But when you look closely at this algorithmic deep dive, it reveals vomiting to be something entirely different. It is a highly sophisticated, deeply integrated, multi-system alarm bell. Consider this. The brain's vomiting center is so incredibly sensitive, so hypervigilant, and so well connected that it constantly tastes the bloodstream for the absolute earliest trace of kidney toxins or poisons.
It's always watching.
It constantly microscopically monitors the fluid in your inner ear for the slightest mathematical mismatch in gravity and balance. It is hardwired directly to the dying muscle cells of your heart via the vagus nerve.
An incredible network.
It acts as an elite, relentless biological bodyguard that is entirely willing to violently disrupt your body, contract your massive core muscles to exhaustion, and forcefully expel your stomach contents simply to protect you from what it perceives as an imminent lethal threat. So as you walk away from this deep dive into the ER, ask yourself this. How else might our body's most violent, uncomfortable, and deeply unpleasant reactions actually be our most advanced, finely tuned, and miraculous survival mechanisms?